I get the opportunity to be kind of the nerd here and tell you about data, because at the end of the day, this is a physician-founded company, and we need to emphasize. You'll see on the panel that we have 5, I think, physicians in this company. And at the end of the day, for us to be successful, we have to be rigorous, has to be data-driven, both ultimately for physician adoption, for guidelines, and ultimately for working with payers as well. And we take that very, very seriously. I hinted at this earlier. If you kind of wind the clock back, not that long ago, maybe many of you have been with us for several years, maybe 6 or 7 months ago, we were leveraging one clinical validity study, which was that original Science Translational Medicine paper. And one of the little secrets about that is that actually only about 90 of those 400 patients actually had their sample collected with EsoCheck. So that's a bit of a testament as to sort of what the unmet need here is, that we never really have had problems with getting physicians to actually respond to these educational activities that Sean mentioned, even though a lot of times in other opportunities where you're trying to sell technologies, it's always like, show me more data, show me more data. We just don't get that, and we didn't even get that back when we were just leveraging that original paper. But the good news is that we've really had an avalanche of data that's come our way, and the clinical evidence base, so hopefully the sort of the nerdish story that I can tell you now going through a bit of this data is that we now have a really substantial foundation of the various types of data that we need in order to continue working on physician adoption, continuing our efforts with regard to payment and coverage and guidelines and so forth. So I'm going to go over those. Hopefully I'll go over them fairly quickly, because I think I'm between you guys and lunch. So Sean already hinted at this. In those in the know, talk about AV, CV, and CU, and sort of the buzzwords. And what do those mean? They mean three different areas, 3 different pillars of our evidence base for a diagnostic test. As Sean mentioned, AV is analytic validity, and that's what Dr. Verma and Martin, who runs our laboratory, that's what they do. And we don't really spend a lot of time on AV, not because we don't appreciate the hard work that they do. This is just confirming that the test works, that the limit of detection is correct. They do it on cell lines. There are all these things that we have to do to confirm that the actual mechanics of performing the test is working. And the reason we don't really spend a lot of time talking about it is because we're a CLIA lab. In order for us to be able to do the test, we actually have to check the AV box at all times, and subject to audits and so forth. So that's buttoned up. So the fact that we're a CLIA lab, we've got a fantastic team. We'll talk a little bit in the fireside chat about a lot of the progress that we've made in that. We have that locked down. So we're really onto the C's, the CV and the CU. Clinical validity is, Stan mentioned that in his video, does the test actually perform ultimately in the intended use population, the patients that are intended to be tested? And those are really numbers you've probably heard of: sensitivity, specificity. Sometimes we actually like couching it as negative predictive value, positive predictive value, and so forth. So how does EsoGuard perform? That's different than clinical utility. Clinical utility is something that actually, me as a physician, I wasn't really that aware of until I got into industry, and I think my physician colleagues would agree. But this is where the payers are really focused, right? Because you want to know, as Sean and others had mentioned, that if you do this test, and from their perspective, if I pay for this test, that it has an impact, that it actually it has an impact initially on medical decision making, so that a positive result goes down this pathway, a negative result goes down this pathway, and the result of your test was what determined whether you go down that pathway. Now you can push a bit further and demonstrate, is there compliance of the patient? Are there certain outcomes that you can highlight? But at the very beginning, clinical utility is pretty straightforward in a test like ours, and that's sort of the linchpin of our conversations and the work Natalie does with our payer. So AV, CV, CU. I'm going to start with CV. This is at the heart of, does our test work? And the answer is, it does. And we actually now have a substantial amount of CV data. Some of them are company-sponsored tests. Some of them are tests that are initiated by the investigators. You can see the STM paper. That was that original paper that we sort of leveraged for many of the early years of the company. I'm going to talk about the BetterNet study in a bit. This was a study that I referred to earlier in the side comment, where they're doing using EsoGuard in patients who don't even have symptomatic GERD, patients who are just showing up for colonoscopy. So that's recruiting. I'm not going to report on that. We do have some interim data from the Cleveland VA that we've incorporated in a pooled analysis. So lots of activity here, a lot of good data. Two of them are lockdown BE, the STM paper and BetterNet, which I'll talk about in a bit. So this is the STM paper, the one that was published in 2018 by the investigators at Case Western. And for those of you who look at these things, I think the analysts do, they've got really nice areas under the curve, 90% sensitivity, 90% specificity. They were able to replicate that in patients who had the cell collection device used for the sampling of the data. So this is what launched the company, and this is really at the foundation of our clinical validity performance. A couple of things about this is, one, as I mentioned, only 86 of the patients who had their test done had it with the balloon. It worked well in that group, but it wasn't the entire population of 400 patients. The other thing about this test, because it was the first time they were using it in humans, they didn't do it exactly the way we do it now, where we take it at room temperature, we put it in our little vial at room temperature, and it gets transported by room temperature. These samples were taken and frozen immediately, stored, and then sitting there frozen, the DNA is preserved for that period of time. So until our next study, which I'll show here, we didn't have sort of fundamental confirmation that this test can give you the same kinds of results in more real-world use where the sample is preserved at room temperature. So that's where the BetterNet study comes in. We reported about this in the midsummer. This is a multi-center study that came out of the BetterNet Consortium. This is a National Cancer Institute consortium. You can see a variety of prestigious institutions that contributed patients to the study. The principal investigator was Dr. Schock at Case Western. This is a case control study, so patients either are selected who are normal, who are known to not have any of the conditions along the spectrum of precancer to cancer, so controls, as well as patients in each of the buckets. Early stage precancer, Barrett's esophagus, short and long segment, and moving all the way to cancer. So this enrolled 365 patients. At the end, 242 were evaluable. And this study is a real world use example. So this is the first study where they tested the EsoGuard test that using 100% of the samples were collected with the EsoCheck device, unlike in the previous study. And the samples were sent to the laboratory in our little room temperature preservative and run from there, as opposed to being used frozen samples. So this has been posted on a PAVmed indexed preprint server. You can actually read it, and it's been submitted. It's currently under review at the American Journal of Gastroenterology. So what are the results here? The results were excellent, and I've used the term unprecedented. I'm not generally someone to use sort of hyperbolic terms, but hopefully, if you pay attention to the slide, you'll understand why we're so excited about these results and how they truly are unprecedented in the history of molecular diagnostics for the diagnosis of cancer and precancer. So cancer, precancer, early precancer, and overall sensitivity for detecting these abnormalities, right? In this condition, precancer is what Dr. Woodruff talked about. It's Barrett's esophagus, right? So all the conditions from the earliest stage of Barrett's esophagus all the way through high-grade dysplasia. The early precancer are the non-dysplastic. So those are at the very earliest period of time. The biologic abnormalities there are going to be lower. There's not going to be quite as much methylation. It's hard to pick up biologic changes. These are not mutations or other sort of complex, advanced genetic changes. And then obviously cancer are people who have the full-blown, who've been diagnosed in a full-blown way. Again, this is a case control study, so it's comparing head-to-head. Our test is comparing head-to-head EsoGuard compared to endoscopy. So, and this is pooled data from BetterNet as well as the STM paper. So we do really well in cancer. So I've put them side by side here, not as a direct comparison, but just to say what do we expect when we use Cologuard? What are we expecting with regard to sensitivities and negative predictive values? What are people getting excited about with regard to liquid biopsy tests for colon cancer? Let's say with the Garden test. So obviously it's not head-to-head. They're different cancers. It's just meant to sort of establish a baseline of what's good. What do we consider good in this area? So on cancer, we're doing great. It's 96% sensitivity. And I will say that the sensitivity since Dr. Verma and Martin and our team took over the laboratory. So since we took over the running of the test since from the third-party contractor, we've had 100% sensitivity in cancers. We haven't missed any. So the 4% that were missed were in the original STM paper. Precancer, this is the part that's unprecedented, right? So we have mid to high 80s sensitivity for a precancer. Cologuard has about a 42% sensitivity for advanced adenomas, so the late stage colon precancers. It's a little bit better in their most recent Cologuard 2.0. It's about just under 50%, but it's still nowhere near the 80% numbers that we're getting. Now, again, we have to get that, as I mentioned at the beginning, and we've reiterated. To have an impact in this cancer, we have to pick it up at the precancer. So thank God we're able to pick it up at these unprecedented levels. What about early precancer? Has anyone ever been able to pick up an early precancer at the earliest stage before you get these changes called dysplasia or high-grade dysplasia? The answer is no. So Cologuard cannot pick up a regular polyp. When you get a colonoscopy, you're primarily getting it for non-dysplastic polyps, and they pluck the polyp out, and you end up fine, and you don't have to get a colonoscopy for 10 years. So it's 0 for Cologuard. How are the liquid biopsy tests doing? Not very good. The overall sensitivity for colon cancer is 83%, but most of that's stage 3 and stage 4. For stage 1 cancer, they're only getting 55% sensitivity. Hardly any advanced adenomas, of course. As Stan mentioned, you're not going to pick up an early precancerous lesion in the blood. So I think it's fair to say these are unprecedented results. They're the results we need in order to have the impact that I mentioned at the beginning. These kinds of tests will often use not sensitivity and specificity, but we'll use negative and positive predictive value because those numbers depend on the prevalence. If you have a low prevalence versus a high prevalence, the sensitivity and specificity are sort of the intrinsic performance of the test as opposed to how it's going to perform in real life. And with a screening test, you want to have a negative predictive value of as close to 100% as possible. So we're at estimated at about 99%. That means a false negative rate of about 1%. We don't want to have any false negatives, but in this particular condition, there's 2 reasons why a false negative rate of 1% is actually fine. And the reason is that, as I said, we're hitting pretty much 100% on the cancers. So that 1% are people who have precancer, right? And more importantly, those are people who would otherwise not have gotten anything, right? We've already said that only 5% of patients who are at risk for having these conditions ever get any kind of testing. So this is not like, let's say, Cologuard saying that, okay, this patient has about a 70% chance of getting a colonoscopy. If they have a false negative Cologuard, then they will likely not get the colonoscopy. They're not getting the gold standard in that setting. So we're really happy with the 99%. And by the way, that's the normal standard anyway. And then on the positive predictive value, that's about 30%. And that's the advantage of testing for a precancer. Again, this is getting a little bit in the weeds here, but stick with me. Does anyone have any idea what the positive predictive value of a Cologuard test is for, Mark, you nailed it, 4%, right? So 96% of positive Cologuard tests have a negative colonoscopy, or they pick up an advanced adenoma. So 30% positive predictive value means about a 70% false positive rate, which sounds high, but in a screening environment, you want to have a very low false negative rate. You don't want to miss anybody, but you want to have your positive rates be at least higher than what it is in the population. So we're talking typically these are like 7 to 10%, so you have a 3-fold improvement in what you're picking up. That's really important from an economic point of view, because if you didn't do this test, you'd have a 90 to 95% false positive rate. So we're getting the false positive rates down. That means less endoscopies. That means it gives us the opportunity to have a really good healthcare economic discussion with the payers. So that's clinical validity. I did mention that those are both case control studies. We are starting to get that sort of holy grail that Stan mentioned in his video of clinical validity testing in the intended use population. So a case control, we already know that these patients have certain diseases or their controls. This is sort of in the wild. These are patients who have risk factors and they're getting screened. So we have our study, the Lucid BE1 study in the Cleveland VA. study, both of which were testing patients in a screening environment. We have a couple of other ones that are working their way through. Again, so far so good. Sensitivity is looking really good, and we combined these two to get our sample size a little bit bigger. So sensitivity overall of about 99%, negative predictive value of 99%. Positive predictive value is going to go down a little bit because these are kind of a lower risk population. Typically, if somebody's already gotten an endoscopy, they're more likely to have advanced disease. But so far, really early here, but so far so good with regard to kind of the definitive data that we're ultimately going to need. And then let's just talk briefly about clinical utility. As I said, clinical utility is really important, but this data is kind of boring, and I'll explain to you in a second why. What's great about this is that we actually have clinical utility data, which, as I said, we didn't have 6 months ago. So that's fantastic. It allows Natalie to do her job and for us to have meaningful conversations with payers. So we have 4 studies. 3 of them have published peer-reviewed publications, as we mentioned yesterday. So there's the original San Antonio firefighter group that was in February, where we tested 400 patients. That was a retrospective analysis. And we have 2 prospective studies. One is the CLUE study. That was a multi-center study that was targeting to enroll 500 patients. We've enrolled about 535. We have the peer-reviewed publications on about half of those patients. That enrollment's complete. And we'll publish on the full data set when we get a little bit further along. We have these 2 registries, which are going to go. They're going to sort of continue to enroll. We've enrolled about 641 patients, and again, about half of those patients have been reported in a peer-reviewed publication. The reason I said this is boring is I mentioned already what clinical utility is for this test. It's very straightforward. That's not true, and the analysts in the room will attest to the fact that there are other diagnostic tests where defining clinical utility is a lot harder than it is here, at least at the medical decision-making level. Again, positive test, you get an endoscopy. Negative test, you don't. That's really at the fundamental level, at the highest level, what we're looking at here, the impact on medical decision-making. And there's really no point in showing the data because the data is essentially 100% concordant. So in all 3 of the published studies, 100% of the patients who had a positive EsoGuard test were appropriately referred for a confirmatory endoscopy. Great, that's one part of the limb. On the other side, the patients who are negative, 98% across these 3 studies were not referred to an endoscopy. There were a couple here and there, and those were generally people who were referred for an endoscopy, but not really for a screening endoscopy. They sort of complained they had other symptoms, they had pain or trouble swallowing or some other reason why it was appropriate, and that's perfectly fine and acceptable in this environment. So that's that. So we have these studies, we're armed with them. We're going to continue to dig further. So there are other levels of clinical utility that you can get into. So for example, the CLUE study, we're collecting data on the patient got their referral, but did they go? So what's at a patient compliance level, did they actually get the endoscopy? So we'll have that data coming up. The registries are really exciting because we're pushing those even further down. So we know whether they got an endoscopy, and we'll get the result of the endoscopy, and we'll be able to provide some correlation on positives. So there'll be further data that will come out of this. But really a great start with regard to our market access efforts with regard to clinical utility. And that is it.